Back to our channel. In this video we are going to start about unruptured ectopic pregnancy. So in previous video we already discussed about ruptured ectopic pregnancy. So what is the diagnosis for this unruptured ectopic pregnancy? The diagnosis which we do is the diagnosis of choice is TVS, that is transvaginal ultrasonography. So in this TVS, if you see an empty uterus, then you can suspect an ectopic pregnancy. Empty uterus, the first sign which it indicates is of course the ectopic pregnancy, or the second sign it may indicate is pseudo gestational sac. And now coming to TVS, in the TVS if you see tubes and adnexa, so here you may see a gestational sac or cardiac activity in tubes, then it is called as Bagel's sign. And we should feel lucky that we have found this, because usually in the ultrasonography we can't find the ectopic pregnancy. Then in that case we should confirm by means of a Doppler, and in the Doppler you will see ring of fire like appearance, ring of fire appearance. And next you will see the complex adnexal mass. So this is all about ultrasonography, that is the investigation of choice is TVS, that is transvaginal ultrasonography. In that if you see empty uterus, then you can clearly say it as ectopic pregnancy or pseudo gestational sag, because pseudo gestational sag is seen in ectopic pregnancy. Now coming to tubes and adnexa, if you see there is cardiac activity, and if you see the gestational sac in the tubes, then you can fix it as Bagel's sign, that is you can confirm it by Doppler. You will see a ring of fire and a complex of adnexal mass. Now let us discuss about decidua. So coming to a decidua, decidua is divided into three types, that is decidua basalis, Decidua capsularis and Decidua parietalis. Already we know that it is divided into three types: Decidua basalis, Decidua capsularis, Decidua parietalis. So Decidua basalis mainly separates the blastocysts from the myometrium, and it forms a maternal side of placenta. About this already we discussed in previous videos. Now coming to Decidua capsularis, it separates the blastocysts from uterine cavity. Next coming to Decidua parietalis, it forms the rest of the decidua. About this I think already we know perfect. Now coming to intradecidual sign. What is intradecidual sign? Actually about this also we discussed, like in an early pregnancy, blastocyst or gestational sac implants deep into the decidua. It is called interstitial implantation, and it will not displace or deform the hyperechogenic central activity complex called intradecidual sign. So let me draw that intradecidual sign. So just it will be like a fish. Okay, so here this black color represents the gestational sac, and this it represents the central cavity complex, central cavity complex. Now coming to double decidual sac sign, it is only seen in intrauterine pregnancy. Intrauterine pregnancy you will see double decidual sac sign, right? So actually what is this is same around this decidua only, around this gestational sac only you will see two rings. This is the central cavity complex, and this which you see on the outside is the Decidua parietalis, and this which you see on inside is the Decidua capsularis. About this already we discussed very nicely in previous videos, so we can check out that. This is Decidua parietalis. So now this is called double decidual sign. Now coming to difference between true and pseudo gestational sac. So true gestational sac is seen only in intrauterine pregnancy, okay, and it is eccentric in location, okay, and it increases in size for every 1 to 3 millimeter per 1 day. Okay, increase in size 1 to 3 millimeter per day, and you will get a double decidual sign positive. Now coming to pseudo gestational sag. Pseudo gestational sag is seen in especially ectopic pregnancy where there is a thick decidua. As there is a thick decidua, it will appear as if it's like a as if it's like a gestational sac, but it is not true gestational sac, and it is centrally located. Normally, true gestational sac will be eccentric, but here it is centrally, so you can rule out it easily. And the size remains constant, but there, if you see, the size is increasing like 1 to 3 millimeters per day, right? And the next thing is here the double decidual sign will be negative, there it is positive. So these are the differences between a true gestational sac and a pseudo gestational sac, which you need to observe. Now coming to TVS findings in unruptured ectopic pregnancy. So on transvaginal scan, what do you see in unruptured ectopic pregnancy? There is empty uterine cavity. So always remember, whenever there is empty uterine cavity, you may feel shock, like you have seen urine pregnancy test, it is positive, but if you do the USG of uterine, you will see it is empty. You are shocked, what is going on? Then immediately you need to do early intrauterine, like immediately you need to rule out these three things in your brain, like either it may be early uterine pregnancy. For example, if you take in vitro fertilization patient, you have done the you have transferred the embryo, but still it takes time to come from the fallopian tube to the uterus and implant. So before that time only, if you go and do the USG, then you will of course find an empty uterine cavity. So that case is early uterine pregnancy. And the second case is abortion. Either it may be get aborted and everything may stay empty, or either it may be ectopic pregnancy, that's why you're not able to see anything in uterus. So these are the three things. So to avoid this confusion in the brain, immediately do beta HCG level values, because the beta HCG levels, there is a critical title. For the TVS, it is like about, it will be 2000 international units, and for the TAS, transabdominal scan, it is 6500 international units. About this we already know clearly, right? So if you do this critical examination, you can easily now you will be able to divide it. Okay, so how you will divide it? According to the values, according to beta HCG values, if the value is greater than greater than 2000, then you can say it's perfectly ectopic pregnancy, because already the value is greater than 2000, but still there is no implant in the uterus, then of course it will be ectopic. But if the value is less than 1500, now you will be confusing, or you can say less than 2000. Okay, so if the value is less than 2000, then you will be starting confused that as it is less than 2000, now again it may have all the chances, like either it may be early uterine pregnancy, or it may be abortion, or it may be still ectopic. So just repeat this test after 48 hours. Okay, so after 48 hours, actually normal pregnancy, after 48 hours the values will double, like they'll become up to 66%, right? So if the values double, then you can confirm it as early uterine pregnancy. Okay, so if the HCG are low, then you can easily confirm it as abortion. Okay, here the HCG is increasing, but it is not doubling. Here it is doubling, right? It here will double. Okay, here it is not doubling. Okay, here it's not doubling, so but HCG is rising. In this case, you can easily confirm it as ectopic. So these are the things which you need to observe. Directly, if the value is greater than 2000, you can confirm it as ectopic, because the value is 3000, but still uterus is empty, so you can confirm it as ectopic. But if the value is less than 2000, you need to repeat after 48 hours, and if it get doubles, then it is early uterine pregnancy. If HCG is dropping, abortion. If HCG is increasing but not doubling, then ectopic. So this is how you need to investigate. Now coming to some other investigations. So in other investigations, you will see that serum progesterone levels. So the serum progesterone levels are greater than 25 nanograms per milliliter. It will for sure indicate the intrauterine viable pregnancy. If the values of progesterone is less than 5 nanogram per milliliter, it will indicate a dying pregnancy. So dying pregnancy is nothing but you can say it as abortion or you can say as ectopic. We call it dying because in this both cases the fetus will die, right? So greater than 25 intrauterine viable pregnancy, less than 5 dying pregnancy. So this is another investigation like serum progesterone levels. Okay, and coming to other investigations like investigation of choice, we know already TVS, transvaginal scan. The best one is transvaginal scan with beta HCG as we have seen before, right? And the gold standard, of course, always the gold standard should be remembered, that is laparoscopy. So one thing I want to remind you, laparoscopy is a gold standard for unruptured ectopic pregnancy. But in the case of ruptured ectopic pregnancy, the gold standard will be laparotomy. Remember this, laparotomy. The word tomy you will get in ruptured. Already remember that the tom has got already ruptured, like that you remember. But laparoscopy, still you have scope, so it's unruptured, like that you should remember this for sure. Okay. So now coming to investigation which is not done in pregnancy. You will not do this investigations at all in pregnancy. Those are like, okay, not done, like HSG, hysteroscopy, colpotomy. So these are the investigations which you will never use. HSG, hysteroscopy, colpotomy, never used in pregnancy. Now coming to management of unruptured ectopic. So actually to manage this you have three things to manage. You can by three ways you can manage the unruptured ectopic pregnancy. One is the expectant management, other one is the medical management, third one is the surgical management. So in the expectant management you will do is first you will wait and watch. Okay, but here the disadvantages are the risk of rupture is increasing more because still it is unruptured. It may rupture. If you will wait and watch you will know nothing, and it is not at all preferred. Coming to medical management is actually the management of choice. Here preferred in case of unruptured ectopic pregnancy, the drug of choice will be methotrexate. So this one you need to very important remember. So medical management is best, it is preferred especially in unruptured ectopic pregnancy, that is methotrexate. Now coming to surgical management. In the surgical management, as I said, you have scope, still it is unruptured, so you have scope, that is laparoscopy. It is preferred, and of course even you can do laparotomy, but I said tomy is already ruptured, means it is used in ruptured ectopic pregnancy. In unruptured you have still scope, so it is best. So these are the prerequisites. Okay, so only in unruptured ectopic pregnancy and hemodynamically stable people you will do all these things. So remember, you will do all these things in already stable patients, I mean. Okay, but in the case like expected, remember that the expected medical management, there are some conditions for this. For expectant, the conditions are the size of ectopic should be less than 3 and beta HCG should be less than 1000, or you can say less than 200 international unit, and it should be decreasing, and the cardiac activity is absent. So only in this cases you do expectant, because what is expected is nothing but wait and watch. So what you will do by waiting and watching, you can do this in the case of ectopic which is less than 3, beta HCG values are less than 2000, and there is no cardiac activity. So now if you wait and watch also, nothing will happen to the fetus, already it is death, right? So now coming to medical management. In the medical management, the cases which you see is the size is less than 4 centimeter. Here the size is less than 3 centimeter. Here the size is less than 4 centimeter and the beta SAG values are less than 5000. So there's a difference here. Here it is less than 1000 or less than 2000, but here it's less than 5000. That kid medical management, and here the cardiac activity may either be absent or present, though there's a dilemma. Okay, so preferably you can say here also it's absent. Okay, so by this we'll end this, and in the next part we'll end this with some other topics which are left behind.